This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Acta Neurochirurgica, published in 2026, titled Microsurgical Anatomy of the Anterior-Inferior Cerebellar Artery, Systematic Review with Meta-Analysis.
This is a substantial piece of work, Alara. When we talk about the cerebellopontine angle, or CPA, the AICA is arguably the most variable and surgically demanding vessel we encounter. This study pooled data from 64 different studies covering over 15,000 arteries. For our residents listening, that kind of statistical power is exactly what we need to move from anecdotal experience to evidence-based anatomy.
Exactly, Dr. Eris. The scale here is impressive. They looked at everything from the origin and morphometry to the branching patterns and, crucially, the relationship between the AICA and the cranial nerves. Let's start with the basics, where this vessel actually comes from.
Right. In the classic textbook description, the AICA originates from the middle portion of the basilar artery, or BA. What did the meta-analysis find?
The data confirms that in the majority of the general population, 90.1% to be exact, the AICA originates from the basilar artery. It typically emerges from the lateral section of the basilar artery and runs posterolaterally, ventral to the pons, within the prepontine cistern.
And then it makes its way into the CPA. That's where things get crowded. The paper describes the main trunk bifurcating into two primary branches. Can you walk us through that terminology?
Yes, and the paper is very specific about the nomenclature. The main trunk usually bifurcates into a superior, or caudal trunk, and an inferior, or rostral trunk. This typically happens at the level where the facial vestibulocochlear complex, cranial nerves 7 and 8, exits the brainstem.
It's a critical landmark. If you're doing a vestibular schwannoma resection or a microvascular decompression, identifying that bifurcation is key. Now, one of the most striking findings in this paper involves the branching pattern itself.
Right. They found that a unilateral branching pattern was present in 85.5% of cases. Understanding this helps us predict the vascular territory. The AICA is responsible for the anterior-inferior surface of the cerebellum, the flocculus, and the choroid plexus of the lateral ventricles. But it also supplies the lower third of the lateral pontine area, and sometimes even the medulla. Which explains why an iatrogenic injury during a CPA tumor resection can be so devastating. We're not just talking about a bit of cerebellar ataxia, we're talking about brainstem ischemia. The paper lists vertigo, dizziness, facial paresis, and nystagmus as primary risks. And even death in the most severe cases of ischemic or hemorrhagic events. This is why the meta-analysis focused so heavily on the relationship between the AICA and the cranial nerves. Let's dive deeper into the abducens nerve, cranial nerve 6.
This was a high percentage, wasn't it?
It was. The study found that the AICA was in contact with the abducens nerve in up to 82.2% of the general population. For a resident performing a transpetral approach or working near the clevis, that's a nearly 4 in 5 chance that the AICA is right there, potentially draped over or tucked under cranial nerve 6.
That's a vital heads up for the OR. But let's move to the stars of the show in the CPA, the facial and vestibulocochlear nerves. The relationship there is even more complex.
This is where the paper provides some really nuanced data. Regarding the facial vestibulocochlear complex, the researchers found that the AICA was located between cranial nerve 7 and cranial nerve 8 in 60.6% of cases.
That is a high frequency. If you are approaching a tumor or looking for a compressing vessel in hemifacial spasm, you have to expect the AICA to be sandwiched in that 7-8 complex. It's not just near them, it's literally part of the bundle in the majority of patients.
And that brings us to the topic of AICA loops, which is perhaps the most clinically relevant part of this meta-analysis for functional neurosurgery.
Definitely. We see these loops all the time on MRI, but this paper quantifies them across different populations. What were the numbers?
Globally, AICA loops were present in 58.3% of the general population. But what's fascinating is the geographic variation the authors uncovered. In the South Korean population, the prevalence of AICA loops reached as high as 77.1%. Conversely, in the Turkish population, it was only 18.0%.
That's a massive delta. It suggests that a surgeon's expected anatomy might need to shift based on the patient's demographics. Why do we care so much about these loops? It's not just an anatomical curiosity.
Right, it's about compression syndromes, or CS. These loops are characteristically connected with tinnitus, hearing loss, and hemifacial spasm. When these vessels compress the nerve, microvascular decompression, or MVD, is often the only way to provide relief. The paper emphasizes that these loops can distort the normal anatomy, making iatrogenic lesions more likely during other procedures, like tumor resections.
And let's not forget about bypass surgery. The paper mentions the occipital artery to AICA bypass. Ilara, in a deep, narrow corridor like that, how does this study help the surgeon?
The authors point out that in such a complex procedure, correct identification of the vessel is absolutely crucial. Because there are so many subtypes of AICA and various looping patterns, the risk of misidentification or injuring a perforator is high. This meta-analysis provides a probabilistic map, if you will, of what you are likely to encounter.
It also mentions how CPA tumors can further complicate things. If you have a large vestibular schwannoma, it's going to displace the AICA. If you don't know the standard relationship, like the 60.6% chance of it being between 7 and 8, you might not know where to look for it when it's been flattened or pushed by a mass.
Exactly. The study concludes that neurosurgeons must keep these variants in mind to avoid iatrogenic lesions. Whether it's an ischemic event in the pons or a hemorrhagic event in the CPA, the clinical symptoms, vertigo, ataxia, and facial paresis, are the same and equally debilitating.
It's a reminder that normal anatomy is often just a statistical average. When 40% of patients don't have the AICA between 7 and 8, or when 82% do have contact with cranial nerve 6, you realize that variation is the rule, not the exception.
The paper really underscores that this standardized knowledge is what will help us minimize risks during decompression, tumor resection, and bypass procedures.
Well, this has been a great deep dive. For our listeners, the key takeaway is respect the AICA. It's variable, it's intimately involved with the cranial nerves, and its territory is too important to lose. Ilara, thanks for bringing this meta-analysis to the table.
Thank you, Dr. Aris. It's definitely a paper that belongs in every resident's digital library.
Agreed. That's all for today's episode of the Neurosurgery Hub podcast. We'll see you in the next one.